My name is Alec Emerling. I'm one of the emergency medicine residents at Naval Medical Center, San Diego, in California. I'm excited to be presenting a lighting abstract for SAEM 2020. Our project's entitled Rapid Sequence Intubation Strategies Among Critically Injured U.S. Military Personnel in Iraq and Afghanistan. I have no conflicts of interest. I'd like to begin with a problem statement and introduction. Civilian and military trauma groups both have the shared goal of preventing preventable deaths in combat trauma victims. Critically ill patients who suffer trauma are commonly exposed to two things, both rapid sequence intubation and blood products transfusion. Eastridge in 2012 showed that preventable deaths from combat trauma are usually due to hemorrhage, in fact 90% due to hemorrhagic shock. A research gap exists to highlight the specific question of the role of rapid sequence intubation, blood product transfusion in this unique critically ill trauma population. Our hypothesis began by asking, do pre-intubation blood products influence hemodynamic and mortality outcomes? We define them as post-intubation systolic blood pressure drop below 70 millimeters of mercury, a drop by 30%, post-intubation pulseless arrest, and mortality at 24 hours and 30 days rather. We also examined whether or not rapid sequence intubation dose influenced these same outcomes. We performed a retrospective chart review utilizing the Expeditionary Medical Encounter Database. We began with 45,000 charts, included only those with an injury severity score of greater than 15, those who received blood products, and those who underwent rapid sequence intubation. We excluded those who were intubated by means other than RSI, had incomplete records, had primary head, neck, or face injuries, were killed in action, or were exposed to return of spontaneous circulation. After this, we were left with 153 combat trauma victims with hemorrhagic shock who were exposed to rapid sequence intubation. The demographics of our patients are listed here. The mean age was 25 years old. The average heart rate was over 120 and systolic blood pressure less than 110. I believe these metrics highlight how critically ill our patients were. Further highlighting this was a mean injury severity score of 29.7. The average amount of blood products before intubation was 2.2 units, and the average amount of blood products given 24 hours after injury was just under 40. We created two dose definitions to ask the question whether or not giving an induction agent dose below the recommendation or above the recommendation influenced the previously mentioned 5 hemodynamic and mortality outcomes. The standard dose, as we called it, was defined by EM in general surgery textbooks, as well as Joint Trauma System Clinical Practice Guideline 39. The critical care definition, we utilized Trauma Critical Care Guidelines in JTS CPG 40. You'll note the 4 induction agents are listed. The only difference between the two definitions, the standard and critical care, is that the critical care definition has slightly lower recommended dose of induction agent. Moving on to the results. Again, when asking, do pre-intubation blood products influence the 5 outcomes, we found that mortality after adjusting for covariates was not influenced. Specifically, 24-hour mortality and 30-day mortality did not influence, had odds which were not influenced by pre-intubation blood products. However, our 3 hemodynamic metrics, pulseless arrest, systolic blood pressure below 70 millimeters of mercury, and systolic blood pressure drop greater than 30%, did have statistically significant influence on the odds from giving pre-intubation blood products. When looking at the standard definition, after adjusting for covariates, whether or not a patient received below recommended dose or above recommended dose, there was no influence on the odds of our 5 study variables. The same was seen using the critical care definition. The limitations of our study are the same of any retrospective chart review. We also had a small sample size, which may have limited our ability to find a statistically significant difference in utilizing induction agent dose. There were many missing records which could have introduced bias in our study. Also, our active duty population may not be generalizable, though an important one to study. We hope that future research can be performed by replicating the same type of study that we performed in other civilian and Department of Defense databases. We also hope to inspire animal model studies and eventually perform our own prospective human research. In conclusion, we found that early blood product transfusion may be associated with decreased odds of post-intubation pulseless arrest and systolic blood pressure. However, that same benefit was not seen with mortality. We also found that induction agent may not have profound of an influence in preventing hemodynamic instability or mortality. Thanks for listening.